people were like, well, do I have to measure SpO2? And we don't do that commonly in the ICU, so probably don't, right? Do I have to give blood? Again, we don't do that. There's a lot of suspicion about early goal-directed therapy of what you need to do, or questions, I should say, that you didn't need to do all of that because it was pretty complicated. If you did, it was fine, but you probably didn't need to do all of that. But what did you need to do? So these 3 trials, which were all published really the same time and were running about the same time, one in Australia, one in the US, and one in the UK, we're looking at, do you need a protocol, and what parts of the protocol do you need? Or can you just do whatever you want? These are all run in big academic centers for the most part, and so that kind of will explain some of the results. But what all patients had, and what these 3 trials said basically was there was no advantage of protocolized care for sepsis over conscientious usual care. Right? Now that's a little bit different than what I've been saying, right? So you can do usual care and not use a protocol. Now, then the question comes, what is usual care in that patient population when they studied it? And you have to know under the circumstances that these were done. Australia has one of the best critical care networks in the world. So it's like a tiered system. Like if you're sick, if you're just kind of sick, you can stay in the hospital you're at. But if you're really sick, they transfer you to you don't have a choice. You get transferred to a regional center, and you're taken care of by intensivists. And that's what they do. They're mainly anesthesia, critical care people there. The process was done in large EDs in academic centers here, and PROMIS was done in the UK system, which that's a whole different story. But they were it was done in teaching centers there too. So what they all had in common though was that early receipt of antibiotics, fluids, and vasopressors, and they all had a high survival rate from severe sepsis. So from Manny Rivers to, that's 15 years, 2001 to 2016. Our care has changed in that time significantly. And so what they basically said is like, well, we've learned a lot in 15 years. We now give fluids up front. We give antibiotics early in these centers, and we get patients who are hypotensive out of hypotension quickly. All these centers, I've gone through all 3 of these trials, looked at them, and they were treated up front before they got enrolled in the trial, essentially almost 30 cc's kilogram of fluid, whether they were on the usual care or protocolized care. They all got fluids, antibiotics, blood cultures, and vasopressors pretty much before they were enrolled in the trial. So they all started out with that, and they saw no difference between the 3 trials, or 3 ways to do it. Usual care, because usual care wasn't usual care from 2001, and then you didn't need all this stuff in the early goal-directed therapy that they were doing before to make it complex. So, again, the comparison of the 3 trials, or the 4 trials, early goal-directed was small, process, arise, and promise all had large numbers of patients. The definition of sepsis was pretty much the same between all 4 trials. Fluids before randomization was pretty much, in process, was 20 to 30 mils per kg. Both of these were 1,000, but most of those patients were getting their 2nd and 3rd liters by the time they were enrolled. The interventions was looking at early goal-directed therapy in all 4. The control was either protocol or usual therapy, and they looked at 60 and 90-day mortality. And what they found is that control group in all of these was, or except for their early goal-directed therapy, was the same here. Okay, so PROMIS, the UK, 30% mortality versus process and arise. So this is where our goal for our sepsis comes from, is that in patients that have septic shock, we would like to get our mortality rate down to less than 20%. Okay, it's a doable thing for patients that go from the emergency room to the ICU. Our mortality data actually includes patients that are transferred from outside facilities and those that come from the floor. And so we can talk about that a little bit more. So what's important in sepsis? Screening. So we now have a ED screening thing, and we're going to be looking at that and see how that's working. But most importantly, recognition of sepsis. I get the call a lot of times, patient's been in an ED for hours, and the ED doc's calling me saying, yeah, I think this patient may have sepsis. I'm like, well, yeah, they did when they walked in the door, and they haven't been treated. Think about that chart where mortality goes up every hour that you don't treat. And does it really matter who cares for the patient? Is it which provider it is? Is it a doc? Is it a nurse? Is it a CNA? I can tell you that if whoever gives them fluids, antibiotics, they're going to win, okay, if they give it earlier. And if the janitor recognizes that the patient's septic, that's may save the patient's life. So I think the one thing that we're doing in the ED here is we're using a nurse-initiated order set so that nurses can recognize it and start treatment and recognition earlier. Where the patient's cared for. There's great studies that look at community hospitals that do a great job taking care of septic patients because they have a protocol. I sat in a lecture one time that they were presenting data from a comparison between Johns Hopkins and a community hospital and the management of I think it was ARDS. And they were debating about the community hospital used a protocol and the Johns Hopkins didn't. And the guy was trying to defend that you don't need protocols to take, this is the reason we don't need protocols to take care of patients. They both got the same outcomes. And one of the docs, said, well, if I'm in that community hospital and I can run a protocol that gives me the same results as Johns Hopkins gets, I'll go with the protocol. It's easy. I don't need to think about it. So, and that's kind of the way I feel about it. Let's use a protocol. Let's use something that gives us a pathway to getting to taking care of sepsis that is good or better than any other place. And there's no reason if you're up in, well, I shouldn't say anything. If you're somewhere else, you should get the same results if you have the right system in place to take care of those patients, right? There's no reason you can't do it. It's easy. So, protocols, antibiotics, fluids, may need a central line, may not. Probably don't need a PA catheter, lactic acid, blood. Those things seem to have come off there. But there's a lot of things that are important in taking care of patients. But the top two are going to be, or top ones, there's really one, antibiotics early and then fluids. Okay. So this is a slide that, I don't know, remember, we had, this is a slide passed around, you'll see this in a lot of sepsis talks. Somebody made this. Because from 2001 to 2016, what's really changed? So I can tell you that in 2001, the recommendations were source control, antibiotics, resuscitation, and supportive care. So that was the core. And then our mortality has gone down from 2001 to 2006. If you look at across the country, mortality from sepsis has gone down from that 40% down in septic shock from 40% to 20%. And we've looked at steroids as, can that help? And then we've had said, no, steroids aren't any good. And there's multiple papers. And we've said, well, maybe steroids. And then probably not. So we've looked at Xigris, which I've already told you, taken off the market because it wasn't beneficial. But when it came out, it was given to everybody with sepsis, and we had what we thought were amazing outcomes. But really what happened was that we had really bad mortality in the beginning, and we added an agent that did improve some people, and it got our mortality down. But then everybody else caught up with everything else we were doing. So then Xigris became not that important. So it was also really expensive to make, so the company got tired of making it. So especially if it wasn't going to be used very much. Tight glycemic control. There was a study that came out that said we should be putting everybody on insulin drips, keeping their blood sugar between 100 and 120 or so. That's a whole nother story. It's a good story, but now we don't do that. We're keeping less than 180 is kind of our goal. Immunonutrition. You guys, Oxipa was the immunonutrition. I got in trouble when I first came here because it was being used here. And I said, we probably shouldn't because it actually increases mortality. And that was, so we don't really know what to do with that anymore. We don't use Oxipa. But there's some other things that are being tried and studied now, but nothing has ever been shown to improve from what you feed a patient in sepsis. And then all the stuff. I think Dan and Zach yesterday were telling me that they had a great idea that they were going to make a nitric oxide synthase inhibitor. I don't know how they came up with that. It seems pretty advanced for those two. But I told them it had already been done, and guess what? Didn't work. But these are all the things that have gone through clinical trials, and both at the basic science level, and they should work. I mean, they should work. The LPS receptor antagonist, anti-TNF, ibuprofen. I remember when we were studying that in the ICU. All these things, anti-TLR4, but unfortunately, none of them have worked. So where are we at? 15 years later, same thing. Source control, more antibiotics, faster resuscitation, and better supportive care. That's really the basis of sepsis care. So what has improved mortality over the last 15 years is the process of care has been improved. Okay, so we have to do it better. So far, I kind of try to sum this up. Look for sepsis, have a plan. When you recognize sepsis, do something. Hopefully antibiotics. If you're going to do anything, give them an antibiotic. And do it the same way each time if you can. Okay? It's not a time for, being an individual. It's a time and thinking about it too much. It's a time for doing a protocol, doing the same thing every time. There's no, the surviving sepsis guidelines, I'm sure they're going to come out with some new ones soon. They come out about every 5 years or so, 5 to 10 years. They get a conference and they make a lot of recommendations. It's about 60 pages if you ever want to read it. I've read the whole thing. It's not that interesting. But there's the thing you get out of it, there's no magic bullets. Okay, there's very few specific therapies for sepsis. The most important thing is early recognition and early treatment. That usually is occurring in an emergency room. There's other important recommendations for the secondary care that occurs in the ICU in these patients. And that's where a lot of the surviving sepsis guidelines focus on, because the early treatment is pretty simple. And let's see, the big thing you get out of it is many interventions are time sensitive. So they look at initial resuscitation, infection-related issues, adjunctive therapy, mechanical ventilation, glucose control, bicarbonate therapy, nutrition, renal replacement, prophylaxis for VT, stress ulcer prophylaxis, setting goals of care. I've tried to ignore this one just because I don't take care of pediatrics and I don't want to. But these are all things that, and if you think about it, most of this is done in the ICU. It's the initial resuscitation that's going to save a patient's life. The basics of acute management, recognition, antibiotics, resuscitation, source control, important things in sepsis, identification is everybody needs to be able to recognize it. You can't say, I'm never going to see it, because if you're working anywhere in this hospital, you're going to see it. Everybody needs to know what it looks like. You need to be able to look at vital signs. We're doing the alerting system in the ED. We've tried it on the floor. We're probably going to do more of that, especially when we get epic. There's really no biomarkers, but they're still working on it, and eventually I bet you they'll come out with some. But they're pretty difficult to do, because it's just a huge immune response that occurs, and there's so much there, it's hard to be specific. Antibiotics. We'll kind of keep hitting on antibiotics, I don't know why. But multiple large observational studies have shown the time to administration of antibiotics to be strongly associated with improved survival. Okay. Now, you always get some jackass who's like, well, there's no randomized controlled trial for antibiotics in sepsis. There will never be one, because nobody's going to withhold antibiotics from somebody who's septic, right? We would get thrown in jail. So, I'm not aware of a single physician that recommends withholding or slowing down the time to antibiotics in a patient with severe sepsis. So again, when you think about it, you see somebody, you think they're septic, give them antibiotics, don't hold it. And then this is really our time to needle or door to balloon or time to TPA, whatever, in sepsis is antibiotic administration. This is a classic study which looks at antibiotic survival in people treated with antibiotics in the first hour. So if you get antibiotics in that first hour, pretty good survival in sepsis. If you wait 36 hours, where everybody's been treated, but if you didn't get it, if it was over 36 hours before you got your first dose of antibiotics, you're kind of in trouble. So those patients don't survive. And again, as a researcher, you like to see this. It goes nice trends, up, down. You can make a nice, pretty slide. This will tell you that every hour that you delay antibiotic administration in a septic patient, their mortality goes up. So this kind of is another study, a couple studies that look at that. The odds ratio here of survival, or odds ratio of death goes up with time. And then also, this is a different study looking at patients who are alive here or dead if they got antibiotics in that first hour. And you can see the white part goes down. The green part, there's just less patients here. The frequency is going down. But the gray part is becoming more and more of the white part. So the percentage goes up. So mortality, 27, 38, 36, 38, 60, 100. So this is just a repeat of that other study, giving you very similar data. The initial resuscitation, again, this is a hard thing to do. We know we have several studies which show that initial resuscitation with fluids improves or decreases the risk of end organ damage. Okay, not many studies have shown that by giving somebody fluids that mortality goes down. But you decrease the amount of renal replacement therapy, end organ damage, ARDS, and those kind of things. So, how to resuscitate? Always think 30 cc's per kilogram. We made it easy in our order set here. It's basically like 2, 3, or 4 liters based on their weight. We don't need to calculate it to the milliliter. That's hard. Nobody wants to do that. Lactated ringers primarily. So if the doc in the ED is ordering normal saline, it'd be a good idea to ask them if it's that you'd rather use lactated ringers. And if they give you a hard time, you can tell them to call me. Okay, we can go over this data. 2 New England Journal papers came out this year which looked at low chloride solutions versus normal saline, and it showed a decrease in acute kidney injury in those patients. Huge trials, not a huge difference, but the most difference was seen in septic shock patients and sepsis. And it's one of my best friends who's the guy who did the studies. So I'm kind of biased, but it's really good stuff, and almost every hospital in the country now uses lactated ringers or another low chloride containing solution for resuscitation in patients based on that. It's been known for a while that this has been out there, but somebody finally did this study to kind of prove it. So if they remain hypotensive after the bolus, start a pressor. Don't let them stay hypotensive. MAP less than 65 or a systolic blood pressure less than 100. And then follow the lactate clearance. You can use lactate clearance, fluid responsiveness, CVP. All have been used. Now there's problems with all of them, and you'll hear docs poo-poo everything, but do something, right? Try to follow something. Good study looking at early lactate clearance as a way to reduce death. Okay, so you can follow the lactate. If the lactate goes down, and use that as your whether to give more fluids or not. Those patients did better. There is evidence that lactate levels are predictive of death and multi-organ dysfunction. Clearance of lactate is associated with improved survival, and algorithms of care based on lactate clearance appear to work. Not great, but it works. You can use SVO2 too. There's that early goal-directed therapy showed that SVO2 works. You can use some of the things looking at cardiac output, those kind of things. You can monitor that. So there's different ways to do it, but it's good to have a way to follow it and do something. So vasopressors. Anybody know which the #1 vasopressor we should be using in sepsis is? It's one we use all the time. Levo, norepi. All right, and they have studied it. So norepi versus dopamine. Try to get dopamine to be used less. It's kind of hard, but there's been several studies looking at it. These don't look very different, but there's definitely a trend towards norepi improving survival in sepsis patients. And then there's been other trials looking at norepi versus dopamine, and dopamine definitely leads to an increase in arrhythmias. When you look at the hazard ratio and look at even larger trials and do a meta-analysis, norepi beats dopamine. So that's why norepi is considered the #1 to use. Again, the problem with dopamine is usually that it causes some sort of arrhythmia in the patients. So, first line, second line, either epi or vasopressin. I can tell you that epi was put in as the second line because the Europeans like to use epinephrine. So no data to support it. Vasopressin, there's the VAST trial which looks at vasopressin, and it's a good second line agent. And phenylephrine is not recommended unless it's salvage therapy, because you're talking about alpha-1. It constricts the arterioles, especially in the periphery. It can lead to more necrosis of the extremities. So shouldn't be using phenylephrine in sepsis and septic shock. And there's no renal protection from dopamine. This is one of the, we hear renal dose dopamine, it drives me insane. But this is one of the few 1A recommendations that you'll ever see in a clinical trial. Norepi, which has good data, is only 1B. 1A, they've done the randomized controlled trial with dopamine looking for renal protection. It does not do renal protection. So I know a lot of people still, some docs around here like to use it. It drives me nuts. Source control, probably also very important. Find out where the infection's coming from, get it out. Okay, so got to get the infection out if you can. Doesn't always, can't take out the lungs if they have pneumonia, but if they have a big empyema, you can get the empyema out with the chest tube. If they have something, a bowel obstruction or something like that, you got to get fixed. You can't sit on it. The chronic phase is what we deal with in the ICU. There's a lot of things. I think that's outside of this talk. But it's everything we've been trying to institute in our ICU. What we do for VAPs, CLAPSIs, COTIs, lung protective ventilator strategies, protocolized sedation, nutritional support, early mobilization. And again, it's a multidisciplinary approach. It's just not a physician writing an order. It's about having that process, or the processes in place so you can get it done. So in summary, have a plan, recognize sepsis early, give antibiotics, give some more antibiotics. For me, I have docs call me all the time, well, I'm concerned about what antibiotic I need to give. I'm like, I don't really care, give something. Don't give doxy, but as far as I'm concerned, give Marum all the time. Marum, ceftriaxone, Zosyn, it's fine, I don't care, I'll change it later. Give fluids, that's also important. If you're hypotensive, your lactate's elevated, give them some fluids. You don't have to give fluids if you're not hypotensive. But if you are tachycardic, which most of these patients are, they will benefit from fluids. It's almost never wrong to give fluids to these patients, even in heart failure. Great look at patients with heart failure. They've looked at them in these large trials, given them fluids, and you know what? They do better. So if they're septic and they have heart failure, give them the fluids. Don't think about it too much. Start pressors, and then get the infection out of the patient. Check lactic acid. So This is our data, looking at the SEP1, which is the early management bundle that's done primarily in our ED. These are our numbers. One point we got up to 90% compliance. Yeah, that hasn't happened since. I don't know what happened that month, but this gets looked at every month and data reported. We're doing pretty well, actually. This is pretty good data. We do a pretty good job in the emergency room of doing our early stuff, but we can do better. We're definitely better than the mean in the country, and we're definitely better than Idaho overall. So, but we can do better. The mortality rate I already showed you. We were having a trend down, which I was really excited about, and then we got this one for this last quarter, but we'll see what the final data shows. Our target's there about 20%. I'd like to get it down, and we can. And then this is looking at the bundle compliance broken down into each thing. So initial lactate we're pretty good at. Broad spectrum antibiotics we're pretty good at. Blood cultures prior to antibiotics we're pretty good at. Repeat lactate, this is pretty good. We've been 100% before, which is kind of cool. Fluids administered with hypotension and lactate greater than 4. We don't do so good with this because we're not giving enough. It's usually not that we're not giving fluids, it's that we're not giving enough fluids. And then vasopressors, we're good with that. This is on us, physicians, which they're going to take out because none of the physicians like it. It's basically documenting in the chart that we looked at the patient when they got up to the ICU, and you have to put certain 3 or 4 things in your note, which we are terrible about. So actually, they're supposed to take it out this year. They haven't yet, but they're supposed to. That's being one of the compliance elements. So let's see. Kind of went over that. And also the lactate issues that we have is more of a documentation and timing issue. So if you get the lactate when the patient comes into the ER, but your time of sepsis is after, like when the diagnosis was made, is after the lactate was drawn, that first lactate doesn't count. So that's just rules along with that. So we do pretty well. What else? We did the ED early recognition and sepsis redesign. We'll see what that data is soon. And then we're working on the sepsis nurse and rapid response nurse, which will hopefully help get some of this stuff done and make sure we get those measures completed. We're going to get point of care lactate. And that's a house, my friend's house in France that I stayed in for a week this summer. So it's better to look at than all that. So, really cool place. All right. Any questions? Yes.
What would you say would be the most common departures from the protocol? Like I was thinking heart failure, I didn't know that they did. They still did better with all the flu bolsters and so on. What might be a departure from protocol that we would see?
Well, I think there's definitely some cases where patients going into pulmonary edema as you're giving them fluids that you would stop the fluids there. There's not too many departures. I mean, the protocol is pretty simple. I mean, you wouldn't not give antibiotics. Sometimes the fluids would be an issue, and you may want to go with pressors, and somebody who's maybe EF's like 5 or 10% or something like that. But even those patients, a lot of times will handle fluids pretty well. You may try to slow it down. I think most of you guys know that we like pressure bags on the fluids. So pressure bags are good. Don't like PICC lines. PICC lines should not be put into septic patients. So because you're putting a PICC line into somebody who you can't really bolus fluids, but the other issue is that you're putting a line into somebody that's not going to get taken out soon that was infected. So they will get contaminated lines, and they'll stop the antibiotics, the line won't come out, and then they'll get infected. So, I don't know. What else?
Do you find that more central lines are being put in the emergency room on the ED docs? I mean, if they're hypotensive,
Yeah,
not
especially the younger docs down there are putting more lines in. So we do see that. I think our group's putting in more lines now
yeah.
than 3 years ago when I